Okay, welcome to chapter 15. Good news. It is the second to last chapter. Only one chapter to go after this one. This particular chapter, of course, is the urinary system. So let's just go ahead and get started. Oh, by the way, there's some construction in the room next to me, so if you hear some banging and pounding and that kind of stuff, it's just them doing some work next door to me. So you might overhear that from time to time while they're working over there. So what's the urinary system for? What's its purpose? Basically, none other than the elimination of waste products, such as nitrogenous wastes, some toxins, even some drugs that we take into our bodies. So that's the entire purpose of the urinary system, is to rid our bodies of things that we don't need anymore. As a consequence to that, we also lose water. So that's the way that it eliminates it. Water's not something that our body likes to get rid of. And it kind of tightly regulates that, or at least it tries to. So there's a trade-off. Get rid of waste, lose some water, and that's why we need to continually be taking water into our bodies. That's just one of the ways we lose water. There's other ways, but that's one of them, one of the main ways. All right, so part of what the urinary system does is it, like I said, it regulates water, also regulates electrolytes. So there's some electrolytes in our bodies, and the kidneys play a major role in that. It helps with the acid-base balance of the blood. It helps to manage blood pressure. It triggers red blood cell production, and it activates vitamin D. So there's several things that the urinary system does other than just to make water. So it's a vital system that we have to have in order to survive. Its components, of course, are the kidneys, the ureters, that are the tubes that lead from the kidneys to the bladder, and then, of course, the bladder, and then the urethra. It goes from the bladder to the outside of the body. Here's just a kind of a simple example of it. We can see the kidneys up here, and we can see the little adrenal glands attached to the top of the kidneys. One of the things I want you to notice about this picture here, it's a pretty good depiction of the fact that it shows, look how vascular this is. Look how much of a blood supply that the kidneys have. Significant amount of blood passes through the kidneys with each and every heartbeat. It's vital that it does that. Similar to the liver when we was in the digestive system, how the liver was kind of a filter for the things that are coming into the body. The kidneys are a little different. It's a filter for the things that are already in the body. It's going to filter things out where the liver tries to keep things from getting in. The kidneys are going to be a little bit more along the lines of what's in there that needs to get out. And in part of that, you know, it's manipulating the things that are in there and getting rid of excess things, and you know, as far as electrolytes and that kind of thing. So, of course, the kidneys are situated against the dorsal body wall in that retroperitoneal space back there in the back. Roughly the level of the thoracic vertebrae 12 and L2, lumbar 3. The right kidney is a little bit lower than the left because of the liver, because it kind of intrudes on that. Slightly protected by the rib cage. You can see there that 12th rib provides a little bit of protection, but not a whole lot. It is possible to injure the kidney by kind of getting up and under that. There's a lot of musculature there too as well, but it's still possible to injure the kidney. The kidneys themselves, they have what's called a renal hilum. It's an indention where the structures enter and exit the kidney. That's kind of you know how they look like a kidney bean? It's kind of the inside part of that kidney bean. You know, the part where everything kind of attaches to it, the blood vessels, the ureters, and the nerves, and all that kind of stuff. And of course, they have an adrenal gland that sits on top of this, and we briefly talked about that, or kind of mentioned that in a couple of different places already in the book. We talked about it in the endocrine system, but we also talked about it in the nervous system when we were talking about the sympathetic side of the nervous system, where it's release of epinephrine, and that comes directly out of the adrenal glands. So we've talked about those adrenal glands a little bit in a couple of different chapters, and they're going to be mentioned again in this one. So there is a capsule that encloses the kidney. You know, we talked about the fibrous coating, or the fibrous membrane that surrounds the brain and the heart and the lungs and other organs in the body. Kidney is the same way. It's a pretty dense fibrous capsule. There's also some fat around the kidney. Most of the time when we look at a cartoon drawing picture like we looked at in here, it doesn't show the fat that's around that kidney, but the reason why there's fat around that is it kind of cushions the blow. You know, if they're from it getting jostled and bounced around, it's protection. The body uses fat as a cushion, so not having enough fat can actually be dangerous as well. We can begin to cause damage to some organs and that kind of thing if we don't have enough fat around our organs. Okay, and then there's this renal fascia that is the outermost capsule that anchors and holds the kidney in place, and it holds that adrenal gland to the structures around the kidney as well. Three structures, there's three regions or structures when we cut this kidney in half that you guys need to be familiar with. The first one is the outer region, or the renal cortex. The next one is the renal medulla. It's interior to that. I always kind of think it looks kind of like a grapefruit. When you cut a grapefruit in half, it's kind of got those little kind of almost triangular regions inside of there. And inside of that renal medulla, there are these renal pyramids. It's kind of that, what I'm talking about, the triangular look. And then there's some renal columns in there that extend into the cortex that kind of separates the materials. Don't worry, we're going to look at a picture here in a minute and it'll give a little better idea. And then of course we have the renal pelvis. And this is basically the collecting area where everything kind of funnels down and it collects the fluids or the urine and the waste products and all that kind of stuff. It collects it on its journey down to the bladder for storage until it is excreted from the body. So looking at this picture here, we can see the renal cortex, and it's the outermost layer out there. And one would think that there's probably not much that goes on up here in the renal cortex, you know, in this area, but there is. And then of course we have the renal pyramids, and this area in here is usually what's referred to as the renal cortex. I'm sorry, not cortex, but I'm lost my train of thought there. The cortex is on the outside. These renal pyramids here on the inside, because they do kind of have this pyramid shape. I'm trying to think of the other word that those are called. That center part of that's called. And then of course here's the collecting ducts. You know, where all these kind of come down and it collects this urine. And we'll talk about how all this works here in just a little bit. So don't go trying to put the cart in front of the horse. We'll talk about how these kidneys work and how they produce urine and all that kind of stuff. And we're going to talk about it in a very detailed way, but hopefully it'll help you have a little better understanding of how these doggone things work. So it's important to take a look at the blood vessel vasculature of the kidneys, because a lot of blood flows through the kidneys. I think it's roughly about 25% of the total blood volume in every heartbeat flows through the kidneys. Very, very dependent upon blood pressure. Have to have a good blood pressure, have to have a normal blood pressure. Too low blood pressure and we don't get perfusion through the kidneys, so the kidneys don't filter and they don't do their job. Too high of blood pressure actually over a long period of time begins to damage the blood vessels. One of the things to think about is we see a lot of patients that are diabetic patients that are on dialysis. What's happened to diabetic patients that are on dialysis, either through no fault of their own, or if they are what we call non-compliant, meaning they're not taking their meds and taking care of themselves like they should, and they're diabetic, that means a lot of times their blood glucose levels, their blood sugar levels get too high. The interesting thing about blood glucose or blood sugar, the glucose in the blood, glucose can actually cause blood vessels to become inflamed. Glucose is actually caustic to tissues in and of itself. It can damage body tissue. So high levels of blood sugar will cause the walls of the blood vessels to become inflamed, irritated, and all that kind of stuff. And over a course of time, they'll begin to get thicker. There'll be some scar tissuing develop, and eventually their ability to expand and contract is compromised, and that buildup begins to get so severe. And then if you add some plaque buildup and that kind of thing from poor diet or fats or just poor genetics, if you add those things into the equation, now you got restricted blood flow going into the kidneys, and once that becomes bad enough, the kidney becomes forever damaged. it no longer can filter like it should, and we wind up with someone that's having to go to a dialysis center and have their blood filtered. And basically they hook them up to a giant machine. This thing is about half the size of a small car, even though our kidneys are roughly a little bit smaller than our fist, and it only takes about a fourth of a kidney to function well in our body, to do most of the work, on a normal day. That we have to use a machine that man created, that is half the size of a small car, in order to do the job of what this small little guy can do on its own. So they have to go to a dialysis center, sit on a dialysis machine, oftentimes for hours. Some of them spend the entire day there, and many of them are there 2, 3, 4, 5 days a week for this dialysis because of the severity of the damage to their kidneys. It's a difficult life. It's very difficult for those that are having to go through this. But that's how sensitive the kidneys are. They're very sensitive. Blood pressure can damage them. High glucose levels can damage them. Low blood pressure can damage them, or at least make them to where that they don't function well. Okay? So, like I said, a quarter of the total blood supply goes through the kidneys every minute. The renal arteries provide each kidney with the arterial blood supply that's coming from the heart. It divides into segments, and it gets smaller and smaller and smaller. And then it's got cortical radiant arteries and that kind of thing. So just a little bit more of a terminology, but don't sweat that terminology. I'm not going to get off into the weeds and be asking you questions about how those break down. And then the veins do just the opposite. They come in from these radiate veins and articulate veins and interlobal veins into a renal vein that returns back into the inferior vena cava, that returns it back to the heart. The interesting thing about the blood that actually passes through the kidneys, that 1/4 of the blood supply every minute that passes through the kidneys, very little oxygen is used out of that blood. So that blood that's returning back to the heart and the lungs is not oxygen poor. So just to kind of give you an idea, just because the blood that goes through our body doesn't mean we use all that oxygen up. Within the kidneys, there are these little things, and they're called nephrons. They are the actual functional unit of kidneys. It's where all the work happens, is in these nephrons. And they are where urine is formed. Now, it sounds pretty simple, but it's actually a little bit more complicated. And then when we look at it a little bit deeper, you'll go, that's not that complicated. It kind of makes sense. So there's two main structures of these nephrons, and the one of them is the renal corpuscle, and then the other one is the renal tubule. Seeing as how we're talking about kidneys and we're talking about the renal system, we're going to talk about renal corpuscles, renal tubules. These are all part of a nephron. Okay? So, some things I want to point out here in this little picture is, okay, so if we take a little section out of here and you see this part of this here is in the renal cortex, and then part of it's down here in the pyramid. So this part is down here kind of in the pyramid part, right? And this is kind of the cortex part up in here. So the top part's kind of in the cortex, the bottom part is in more of the pyramid, or in the medulla. That was the word I was looking for earlier, but I couldn't remember. So this part down here and down in here is the medulla part of it, okay? And then we have this, here's a cortical nephron, because it's in the cortex, right? The entire nephron, this thing right here, is in the cortex. So it's called a cortical nephron. Don't get real caught up into distinguishing between the two, because I'll be honest with you, I'm not going to ask you questions that makes you distinguish necessarily between, well, I might ask you a question, and what I would want you to come out of that is a cortical nephron is in the cortex of the kidney, okay? And then the jugulomedullary nephron extends down into the medulla, okay? So if it has medulla in it, then it's going to be one that extends the bottom part of this nephron right here. It starts in the cortex, the top part, and then it extends down into the medulla, and then goes back up into the cortex. So it kind of extends down in and then goes back up. What you need to realize is down in here is where all the water loss per se is happening. It's a little more complicated than that, but kind of where the water loss is happening. Water loss, actually, some water loss is happening there, but it's being reuptaken, and then it winds up, the urine that's produced winds up going down this little tubule here, and you can see all these little connections on it, okay? So what we have is we have this glomerulus here, right? And you can see that's fed by an artery that's coming in. So it's got blood flow coming into this glomerulus here. That is where all this fluid and blood, red blood cells and plasma and all that stuff that's in the blood is being forced through this glomerulus, okay? So that's kind of what's happening there, and it's kind of a structural look at what we're talking about. But this nephron here, the nephrons here, we'll get a lot more in depth in talking about those here in just a few minutes. So, in that renal corpuscle, it contains that glomerulus that I talked about. It's just this knot of capillaries. And that renal corpuscle is just the entirety of, let me see if I can't circle it here. It's the entirety of this here. Inside of here is the glomerulus, and this is the corpuscle, okay? Hopefully that makes sense. But inside of that corpuscle, you have the glomerulus. And then we have the glomerular capsule, which surrounds the glomerulus. So it's just this space inside of there that kind of surrounds the glomerulus. And I'll explain why that's important. So we've got this corpuscle, we've got a glomerulus inside of it, and then we've got this capsule, this space inside of there that's around the glomerulus. And it's basically the first part of the renal tubule. So if we look at this here, we can see this whole thing is the corpuscle, okay? This is the glomerulus inside of here, and then this space here is considered the capsule, Bowman's capsule. So that's just what's happening is this blood is being pushed in through here, and as long as the blood pressure is high enough, that pressure actually, you see the little holes here on this? And that's really a dramatic look at it, but the pressure actually forces smaller things such as fluid and elements or nutrients and different types of things that are in the blood, toxins and drugs and all that stuff out through those holes, everything but red blood cells. Red blood cells, white blood cells, those kinds of things stay inside of this space here, and they'll make their way back out here. But the blood that's coming out of here is really a lot thicker. It's a lot thicker, it's a lot heavier, it's less viscous. It's lost a lot of viscosity because it's lost a lot of fluids that is now fluids and electrolytes and all kinds of stuff that's now in Bowman's capsule here, and that's going to work its way this way. Because as more blood comes through here, the pressure of that fluid being pushed out of here is actually going to push these fluids out as well through that capsule. This blood, now that it's pretty dehydrated and nutrient poor, it's basically red blood cells and a little bit of fluid, just enough that it keeps moving out. Moves out, down, and out of that. It's not done here. This blood here that's coming down here is not done yet. Okay? It hasn't left the kidney. It's going to circulate around a different part of the nephron and re-pick things up before it goes out of the kidney. Okay? So that's what's happening there in that particular area, in that glomerular capsule. And of course, we can break down Bowman's capsule, that capsule, into 3 different areas. Of course, Bowman's capsule is actually, though it's that capsule around the glomerulus, they extend that capsule because it's all one piece. They extend that all the way down the full length of the nephron. So Bowman's capsule is actually that whole length of tube of the nephron, which I'll show you here in a minute. And it has a proximal tubule, it has a nephron loop, and then it has a distal convoluted tubule. And one of the things I want you one of the things I want you to take note of, it won't be so significant right now, early in your career, of course it might be to some of you, is that right there, the loop of Henle. It's something we're going to talk about a little bit later, but just because I want to kind of use it as a talking point for us. But so if we look at this nephron, you guys can see this nephron here. If we look at this nephron, we see the bottom part of this nephron down here, you know, blood's coming in, Bowman's, there's the corpuscle. Corpuscle's right here. The start of Bowman's capsule right here in this area, in this blank area, and then it's going to push that fluid up into there, right? Well, this, where it starts to push this fluid up in here, is what's called the proximal convoluted tubule, okay? So this part up here is the proximal convoluted tubule. Now notice, when I pointed out to you that those, the blood that came into this capsule right here, you see these loops that it takes in here, and it pushes all those fluids and nutrients and drugs and waste products and everything, good and bad, out. All of it, good and bad, gets pushed out of here. Now we have this really thick, highly concentrated red blood cells and white blood cells with most of the nutrients. There's some other things that are just too big to fit through these holes in here that stay in there. Now you notice that this is coming out, and it's going to loop and interweave all around the proximal convoluted tubules and even the distal convoluted tubules. Proximal, if you think back to the very first chapter when we talked about proximal and distal, proximal closest to, distal furthest from. Proximal means it's closest to the glomulus. Distal means it's further away from the glomulus. That's really all it is. So you have proximal and distal, and what separates proximal and distal is this loop down here, this loop, the loop of Henle, and that's just this whole loop that this thing takes. That's the loop of Henle. That separates proximal from distal, okay? It's just simple as that. It's just pure geography. Now this blood vessel that's looping around here, around this, it's looping around this because now this Bowman's capsule, this capsule here in the proximal convoluted tubule is actually starting to leak things back out. There's specific channels in here that it's allowing good nutrients that the body wants to keep to leak back out and be picked back up by the blood. Okay? Probably a little bit of fluid too, not a whole lot, but a little bit of fluids are going to be picked up there. And different things are going to be picked up in different areas, proximal and distal in the loop. It has different channels and gateways that are going to open up and allow fluids to move in different directions, nutrients and fluids to move in across those membranes and be reuptaken by the blood vessels. So what's happening is, just to recap, right up here, we pushed all the fluids, good, bad nutrients, that kind of stuff out. Remember, red blood cells, white blood cells, even some other nutrients and fats and some other stuff like that that won't fit through the walls of these capillaries here, stayed in the blood vessel. Now this blood vessel's moving this way and these fluids are moving this way. And the reuptake process is beginning here to start to reuptake. Not much is happening up here in the proximal, but some things are starting to happen there where it's starting to reuptake some of those good nutrients and leave the waste products in the tubule, okay? Works its way down here. More stuff is reuptaken. A lot of water is reuptaken down here. This has a lot to do with sodium down here. Potassium, I believe, is more up here, or it could be more over here. I can't remember. But potassium's in a different area. Very sodium dependent down here. The interesting thing about sodium that I want you to remember is, and you probably know this, but water follows sodium. So where we have sodium movement, we oftentimes have water movement. So this tubule down here needs to be very selective in a lot of ways so that it can let go of fluids or retain fluids but get rid of too high sodium levels and those kinds of things. So a lot of things are happening in this thing, and what it's doing is it's trying to get rid of all the waste products and those kind of things that it doesn't need, and even excesses of things that shouldn't belong. Through that process, it actually pushes everything out, or nearly everything out, good and bad, and then it has to reclaim the things that it wants to reclaim or that it needs to reclaim that the body still needs. Basically it in a nutshell. So we have these cortical nephrons. Remember, those cortical nephrons are the ones located in the cortex. And then we have the juxtamedullary, juxtamedullary nephrons that have that loop that goes deep down into the medulla. And that's how you can keep the two of them separate. And then they have collecting ducts. Same picture again, sorry. There's two capillary beds that are associated with each nephron. We have the one in the glomulus. Remember, that's where everything's pushed out. And there we have the peritubular capillary beds, the capillary beds that surround the proximal and distal and the loop of Henle. So we have that capillary bed that surrounds those. The glomulus is where we lose all the fluids and nutrients, and the peritubular capillary beds is where we start to reclaim the good stuff, but we leave the bad stuff inside of that tubule. Okay? We've talked about this. The glomulus is fed and drained by the arterioles. Of course, we have the afferent and efferent arteriole. Of course, afferent is where it's going towards. Efferent means it's going away. So it's that same terminology that we've had throughout this course. So afferent going towards, efferent going away, and that's just where that artery is going in the glomulus that we've looked at a picture of a couple of times. That's where that filtration process occurs. High pressures force those fluids out, and right here is the afferent and efferent arterioles. It points to them right there. High pressure uses the pressure of blood, or blood pressure, sorry, to move those fluids around. And then we have the peritubular capillary beds, but they come from that efferent arteriole that comes from the glomulus, like I talked about. Usually low pressure, and a lot of the blood's a lot thicker in there. And these are designed to reabsorb some substances that need to be reabsorbed. And those will drain back into the veins inside of the kidney, and those veins will get bigger and bigger, and then it'll drain out of the kidney and into back into the superior or inferior vena cava. So another picture. So the formation of urine is the result of three processes happening in the kidney. Glomerular filtration, where we pushed everything out. Tubular reabsorption, where we've reabsorbed the good stuff. And now we've got tubular secretion, which is basically all the waste products with a little bit of water that's left in the form of urine. Basically, that's it in a nutshell. That's how that works. So, this is just a little kind of a picture of what we've talked about so far. We've got this glomulus up here, fed by an artery. Afferent artery comes in here, pushes stuff out. We have glomerular filtration. Efferent artery comes out, and then we've got the capillary bed down here, the peritubular capillaries down here, where even in here, in that particular area, you can see that number 3 here, where we're actually secreting hydrogen and potassium out. Hydrogen, potassium, creatinine, and some other drugs are removed from that artery and vein, that capillary, in this particular area. So this is one of the things that's kind of unique, where this forces everything out. Down here we've got channels that either push things, or that allow things to come out or allow things to come in. Remember those channels, those potassium, or not potassium, well, we actually had sodium and potassium gated channels, but those channels that are that use proteins and that kind of thing, that open and close and allow things through and all that kind of stuff based on hormonal changes or content or the levels, filtration levels and that kind of thing. So that's all that's happening there. Right there, we're reabsorbing some good stuff, still maybe trading off to get rid of some excesses of stuff. Remember, too much hydrogen, too much potassium can be a bad thing. So we need to regulate those, so we may need to get rid of some of them, and that's where we can get rid of some drugs and stuff right there too in that particular area. So we're reabsorbing and getting rid of. Remember that initial filtration in the glomulus is non-selective. Water soluble, anything that'll fit through the capillary walls is going to get pushed through the capillary walls. Some proteins, blood cells, those kinds of things that are too big are not going to go through. And then what's pushed through is collected in that capsule, and then goes down that tubule system and it begins either reabsorbing some of those things that are needed to be reabsorbed, and maybe even getting rid of some of the things that were not able to be forced out through the initial filtration process. It may go ahead and try to kind of refine some of those things in taking them out of the blood. So a couple of conditions. Oliguria is abnormally low urine output, and anuria is less than 100 mils of urine produced every day, and means without. So that's should kind of help you understand that one. So the peritubular capillaries begin to reabsorb useful things that the body can use. Chief among those is water. Some of it's glucose. Remember, glucose is pushed out here. A lot of glucose is pushed out. So remember what I told you, glucose can do the tissues. So high levels of glucose in the kidney not only are going to damage the vessels, but they're going to damage the tissues of the kidney as well, cause inflammation, scarring, and all kinds of damage to the kidneys to the point that they won't work if those are excessively high levels for a long period of time. Some of the reabsorption that goes on there is passive. A lot of it is active. You remember how the sodium-potassium pumps? A lot of it that's going on there may be actually pumping things against the grain, meaning maybe actually pumping, more out or more in that is, against what the normal concentration of that is. Most of the reabsorption occurs in the proximal convoluted tubule. So most of that reabsorption occurs in the proximal tubule, the one on the other side of the loop of Henle. So that's where a lot of that happens. So if we look at this is a really, really good picture here, depiction. So got our little glomulus here, right? So all this stuff is forced out here, and then we've got the proximal tubule. And we can see there's a lot of stuff being changing places either. And any arrow pushing out like this means it's being reabsorbed back into the body. An arrow pushing into the tubule means it's being gotten rid of into this collecting duct, okay? So some things are going out, lots of things are being reabsorbed. This continues on this path, but I want you to notice not much water right here is being reabsorbed. Most of it's nutrients that are being reabsorbed. This travels along this, and now what you see in the descending loop here is a lot of water is reclaimed back into the body. Okay, lots of water is reclaimed here, and then on the other side we have sodium chloride is being reclaimed on the ascending side of the loop of Henle. There's also some water reclaimed here, water reclaimed here. So water's being recollected all throughout, and even over here, all throughout the entire tubule. But right here is significant because there is a medication that we commonly give. We give for somebody that's retaining too much water. Sometimes it's given for people with high blood pressure to help manage their blood pressure. But it's called the water pill. We give them a water pill. So we give them a diuretic. Usually it's Lasix, and that's the one that I'm referring to. So we give them Lasix. We give them Lasix. What's interesting about Lasix, if you read the literature on Lasix, Lasix is going to tell you that its chief place that it acts is in the loop of Henle, and it prevents the reabsorption of water into the body. So what it's going to do is Lasix is going to, down here in the loop of Henle, going to prevent or dramatically reduce the amount of water that's being reabsorbed back into the body. Now, these places up here are still going to be reabsorbing water, but we've taken out one of the big areas that reabsorbing water, or we've slowed it down. So now we're going to keep more water in the tubule going this way, and our bladder is going to fill up faster because we're not reabsorbing as much water, and that's what Lasix does. It works right there in the loop of Henle. I would love to be able to tell you how Lasix does that and how it works, but it's honestly, it's fairly complicated, and I don't fully understand it myself. But what I do know is it works, and right there it works in the loop of Henle. So That's where a lot of our water is reabsorbed. If we don't reabsorb the water from our kidneys right here, we will dehydrate and die relatively quickly. It won't take long, and you will die probably using the bathroom, because you'll be just draining all kinds of water. So you need to realize how much water is filtered and reclaimed here. It's a lot of water. So we're going to get rid of some bad things. Some things that are good we're going to get rid of. Sometimes it's a trade-off. If we want to keep this good thing, we're going to have to get rid of this good thing. So it's kind of a balance. It's kind of always ebbing and flowing, trying to figure out, the body's trying to balance which one that it's sacrificing to keep and get rid of. So the nitrogenous waste products that we don't want are not well reabsorbed. There's just not a good way to reabsorb them because they're not designed to do that, such as urea, uric acid, and creatine. So we get rid of those, which is a good thing because that's what the kidneys are made to do. They're supposed to get rid of those things. That's why they don't reabsorb them. So basically, that tubular secretion is reabsorption in reverse. Like I talked about, some materials move from the blood to the tubule, and some move from the tubules to the blood. Hydrogen and potassium ions are one of those things that's kind of, sometimes they're traded, one for the other, one sacrificing one for the other. If we want to hold on to hydrogen, sometimes we lose potassium. If we want to hold on to potassium, sometimes we lose hydrogen. It's just kind of one of those things. The interesting thing about it, though, is, I'll back up here, when we give somebody Lasix and they lose a lot of water, one of the things that they don't reclaim real well is potassium. They also lose a lot of potassium. So we have to oftentimes, you should see someone that's taking Lasix every day. They should be taking potassium as well because they don't reclaim the potassium if they're not reclaiming the water well. It just comes with the territory. Okay. Why is this secretion important? Get rid of things that are not already in the filtrate, so we're able to kind of secrete some things out and in through that, the other parts of the tubule, and not just relying completely on what's being filtered. Drugs, excessive ions, this is where potassium, hydrogen, those things come into play. We can get rid of that. We can maintain acid base by regulating the hydrogen. And what's left, we move it towards the ureter to get it out of the body. So, another picture. 24 hours, about 1 to 2 liters of urine are produced in a 24-hour period. Urine and filtrate are different. Realize that urine is the final product after we've reclaimed what we want to keep. Filtrate's going to have good, bad, ugly things in it, and may not have some things in it at all, like some drugs that are going to be filtered out later on in that tubule, through a little more active means. So once it's all said and done, urine is what remains. The yellow color of urine is due to a urochrome pigment from the destruction of the hemoglobin of red blood cells. As urine gets more dilute, the urine gets a little bit more pale, but as urine gets more concentrated, that becomes darker. Sometimes we can tell by the color of someone's urine whether or not they're dehydrated. It shouldn't be the only indication that someone may be dehydrated, but it is a helpful indication when we're able to see their urine color. Of course, got to be a little bit careful about that. You need to have some other indications that it's dehydration, because dark urine can also mean that there may be an infection, or even some kidney damage or something like that, kidney stone, where there's some blood in the urine as well. So it's not an entirely accurate indicator, but it's a way that we can kind of rule things out possibly, or rule things in. Urine is sterile. Believe it or not, no, it doesn't have living cells in it, or it shouldn't. If it does have living cells in it, it usually means there's some sort of damage or infection going on in the kidney. Slightly aromatic, maybe a little more aromatic for some than others. And I've heard that if you eat asparagus it becomes more aromatic. I don't know. I'll have to take somebody's word for that. I don't care for asparagus. Normal pH around 6, so it's slightly acidic. And it has a specific gravity of whatever that is. So, some things that are normally found in urine: sodium and potassium ions. There are specific levels that they can test to know what's normal. Urea, uric acid, creatine, ammonia, bicarbonate ions, all of those things that are normally found in there. And there's normal levels for those. So when we do a urinalysis on somebody, we can measure those levels. And plus, we can also look for some other things that may be present that's not supposed to be present in urine to maybe get a better idea of what's going on. Things that shouldn't be found in urine: glucose, blood proteins, red blood cells, hemoglobin, pus, bile. Those kinds of things are an indicator if something is going on and we want to figure out why. It's a red flag. So they do test for those when they do a urine test. Negative results on those means things are good. Positive results on things means we probably need to run some more tests and find out what's going on and what's causing that. Okay, so from the kidneys are the ureters. Basically a simple slender tube that attaches the kidney to the bladder. And it just has the urine trickle down it and gradually fill the bladder up. It runs behind the peritoneum, so there's really little risk of it getting obstructed and plugged off by a big meal that we eat or something like that. And of course, the same peristalsis that moves stuff through our digestive tract, or at least similarly, helps aid that, as well as gravity helps that stuff move down. But you will still produce urine while you're laying down in bed. Trust me on that one. What's the first thing that most of us do when we get up after we've been laying flat? So it doesn't rely completely on gravity. The peristalsis kind of helps that. So we can see that diagram that we looked at there at the beginning, and we see the bladder all the way down there at the bottom. Similar in many respects to this point, male and female. Really not much difference other than when we get down there to where the bladder's at, there starts to become some obviously some structural differences internally, just because the organs are different. The bladder is smooth, collapsible. It's a muscular sac, just a temporary storage house for urine, which is handy. Could you imagine if we didn't have a bladder? We would be trickling and dribbling and dripping all the time. So I would imagine the people that own the Pampers and Depends companies would be they would be like the wealthiest people on the planet. They would be the Bill Gates of the planet, because we wouldn't have anywhere to store our urine if we didn't have a bladder. So it would be very inconvenient. So fortunately we have that. And then of course in males, the prostate surrounds the neck of the urinary bladder. That's important because as males age, oftentimes they end up with a condition called BPH, which is benign prostatic hypertrophy, meaning inflammation or swelling of the prostate, or even hardening a little bit of the prostate. Benign means that it's not cancerous, it's just a normal effect of aging. The problem is it can begin to affect the flow of urine out of the bladder and make it more difficult to urinate. It can be very inconvenient, and it can sometimes be very troublesome for some men as they age. It can become a more progressive and much more difficult. There's a lot more medications for that than there once was, and I think they understand more about it. However, if they remove the prostate for whatever reason, then it forever alters the sexual ability and the sexual drive of the male. So the prostate's very important to that. So it's kind of a lose-lose situation. So we see the bladder, we see the ureters coming into it. It looks a little bit like a little alien thing. Much like many of the other openings that go out into the world, out of our bodies, there's some sort of a sphincter, a musculature that kind of controls how things exit or enter the body. There's a little bit of control there, at least in the bladder. It kind of holds everything back to keep us from going when we don't want to. Unfortunately, with women, as women age, this muscle here becomes more and more difficult to control, especially after childbirth and with age. It becomes more difficult to control that just because structurally the way women are made, it's tougher because there's more opening space inside of a female than there is a male. So it makes those muscles less strong and have less ability to actually hold back the urine in every instance. So coughing, sneezing, laughing can be problematic or have the potential to be problematic. Ask most women that have had a baby, and they've struggled with this because pushing, as wonderful as childbirth is and as wonderful as having children is, it's a very traumatic thing for the mother's body. It's tough on the mom's body to go through that process, and that's the next chapter, though. All right, so 3 layers of smooth muscle make up the outer wall of the bladder, and then it's got this transitional epithelium. Basically, this bladder can expand so significantly without increasing the pressure that it creates on the inside. So this thing can thin out to very, very thin, but still remain very strong and not be creating pressure inside of the bladder just by stretching out. So it's a pretty amazing ability that the bladder has in order to be able to stretch out like it does. It can stretch out about, a moderate full bladder is about 5 inches long, holds about 500 mils of urine, but it's capable of holding about twice that amount. Probably every one of us has had one of those instances where we think it was holding 3 times that amount, or at least it felt like it. And it's always the most inconvenient times, like when the captain turns on the seatbelt sign as you're approaching the airport, and it's like, wait, I got to go. I can't hold it. I got to go. That's usually when that kind of thing happens. At least that's what it happens to me. So the urethra is actually the tube that carries urine from the bladder to the outside of the body, and the difference is in males and females. Of course, obviously the function for males and females is a little bit different. In females, it only carries urine. In males, it carries urine and sperm. The big differences with this is too, in males is that urethra is longer than it is in females, and this makes females much more susceptible to bladder and urinary tract infections than men. It's just purely has to do with the way that males and females' bodies are made. It makes women much more susceptible to UTIs and those types of things than men. Of course, it is absolutely possible for men to get UTIs as well. Okay, so the release of urine is controlled by 2 sphincters, an internal and an external one, which is kind of nice. It's got 2. Not so great when both of them aren't working right. Like I said, with women, the length of the urethra is about 1 inch long. With men, it's about 8. And of course, locations are different, for male and female, obviously, because the anatomy is so different. And for men, it does have to pass through or pass by or through or within some other structures within the male bodies before it actually makes it out through the external opening. So it's got to get through the prostate and all that kind of stuff. All right. Urethritis is an inflammation of the urethra, usually caused by infections. Cystitis is a bladder inflammation, and of course, polynephritis is a kidney inflammation. These are all medical terms that you would probably see a physician write down. They would document that they were diagnosed with blah, 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 that kind of thing. Most of the time they would call this a urinary tract infection, a bladder infection, or a kidney infection is what they'll tell us common folk, so we understand what they're talking about. Micturition is, or voiding, just basically going to the bathroom. It's a process of emptying the bladder. Basically, it's a process that's controlled voluntarily, and unless we have a condition that's called incontinence, which is our inability to control that for whatever reason. A variety of reasons can cause that. Stroke, medical conditions, sometimes surgeries, cancers and that kind of thing. You know, any kind of treatments and even some medications can cause that. And of course, urinary retention is the inability to empty the bladder. Oftentimes we see this with men that do have prostate issues. They're unable to completely empty the bladder, so they almost always have the sensation that they need to go to the bathroom, and yet it's difficult for them to go to the bathroom, so it can be a very uncomfortable, unpleasant thing to have to deal with. Talk a little bit about fluids, electrolytes, and acid-base balance. I know it's kind of switching gears here, but because the kidneys deal so much with fluids and electrolytes and all that and do play a role in acid-base balance, it's important to discuss these, and this is as good a place as any to talk about them. There are three factors, of course, that affect the composition of blood: diet, cellular metabolism, and of course, urine output. If we don't bring the right things in our body, it's going to affect our blood. If our metabolism is off, either fast or slow, it's going to affect it. And of course, if our urine output is subpar or over the top, it's going to affect that as well. So the kidneys have four roles in maintaining that blood composition. So they're going to get rid of nitrogen-containing wastes. They're going to maintain water balance in the blood, and we've talked about how they're going to do that. They're going to maintain electrolyte balance in the blood, sodium, potassium, those kinds of things. It's going to work with those. And then it's also going to help with pH by getting rid of hydrogen or retaining hydrogen. Realize that hydrogen removal process is the slowest of the processes for compensating for hydrogen, but it's also the most efficient. It's the most effective, most long-term effective one. So it's slower, but it lasts longer. It has longer lasting effects, I guess. So normal amount of water in the human body: young females about 50% water, males about 60%, babies are about 75% water. Elderly, as we get older, we get drier. We begin to dry up, I guess, about 45%. And of course, we got to remember water is absolutely critical for many of the body functions, and it's vital that normal levels be maintained. They say that the majority of the American population wandering around today with all of its access to all of the great things that we have access to, most of Americans are dehydrated. We don't get enough water. And I'm not talking about a glass of tea, pop, coffee, a beer or anything like that. I'm talking water, regular old water. We need to be drinking a lot more water because that's what our body needs. Water is going to occupy three main fluid compartments. The first one is intracellular, inside of the cells. The second and third are extracellular, which is outside of the cells, and that includes fluid in our tissues and then fluid in the blood and the cerebrovascular spaces and all that kind of stuff, lymph and eyes and all that. So those are the three places that fluid or water fluids occupy. Now remember, there is a link between water and salt, and I don't know how much we've talked about this before. Remember, the body has all of these electrolytes, such as sodium, potassium, and calcium ions. We talked about that to the nth degree. Changes in these balances causes the water to move from one compartment to another. Remember, when we talked about diffusion way back in the early chapters, and if you have a higher concentration of sodium on one side of the equation than the other, what's easier to happen? It's easier for the fluid to move from one side to the other than it is for the solute or the electrolyte to move from one side to the other. So usually it's water that moves before the solute does. Now eventually it'll balance back out, but the fastest thing that happens is one dilutes the other. Remember, we talked about hypertonic, hypotonic solutions and creonation and all that kind of stuff. You might have to drop back a few chapters and look at that again. I believe it was the chapter on blood. So it's important that those balances are maintained, but it's the water that moves initially, and eventually the electrolytes are going to move as well, but the water is the easiest thing to move. And the movement of water is going to alter the blood volume and the blood pressures and all that kind of stuff, and it can impair the activities of the cells and do all kinds of things. If our electrolyte balances are out of whack, it's going to move the water around in such a way that can cause other things to not work very well. So it's important that we not only maintain a healthy lifestyle and healthy electrolyte levels, but we need to make sure that our water intake equals our output. And some of the ways that we can do that is, of course, we get water in the foods that we take into our body and the fluids, and there's even a little bit of water produced by the metabolic processes within our body as well. But that thirst mechanism is the one main thing, the driving force behind what will make us want to drink some water. So that's basically why water is important and how water is regulated. Part of how water is regulated. We're going to talk a little bit more how that's regulated. So we have this thirst mechanism. We've got these osmoreceptors that are sensitive in the cells of the hypothalamus that react to changes in blood composition or by becoming more active. So when they're activated, the hypothalamus is notified. We start to get a dry mouth. Those kinds of things will kick the thirst mechanism in. And these are all things that make us want to have something to drink, want us to have a drink. I always find it interesting that, I'm rarely do I have the sensation or the want to say, I got to have a drink of water. Sometimes I do. But sometimes I'll just be taking an aspirin or something like that and take a drink of water to chase the aspirin down or Tylenol or whatever it is. And I'll just all of a sudden just want to drink 2 glasses of water when I do that, just to get the taste of water, and all of a sudden I want more. I just kind of crave it just that quickly. That's part of that thirst mechanism. My body's telling me something. Hey, dummy, you need some water. Part of my problem is I think I'm one of those people in the population that instead of my brain saying get a drink of water, my brain says you need to eat something, and that's not good. It's not good for me. So ways that we lose water, of course, are with our, through our lungs. It's insensible, the insensible way we lose it. We can't see it leaving, or we can't sense that it's leaving. It's just in the moisture in our breath. When it's cold outside and warm in your house, breathe on the window or on the window in your car and it fogs up. That's the moisture in your breath that it's exhaling from your lungs that you lose. Perspiration's another way. Feces, a lot of times we don't think about how much water we lose when we go number 2, but we do lose some water when we go number 2, which is a good thing. I can't imagine going number 2 if it was all completely dry and void of water. It would not be a pleasant experience, I can imagine. So hormones are what regulates the reabsorption of water and electrolytes in the kidneys, so it's regulated by hormones. There's one hormone in particular, the antidiuretic hormone, that prevents excessive water loss. Antidiuretic, meaning it opposes diuresis. Diuresis is the loss of water. When we call a medication that we say that pill is a diuretic, what it means is that pill will cause us to lose water. It will cause our bladders to fill up faster, and if we take it at night before we go to bed, we're probably going to be up 3 or 4 times during the night going to the bathroom in a staggering stupor, wondering why we took a diuretic pill before we went to bed. So this hormone, though, is an antidiuretic hormone, meaning it's going to make us hold on to water, right? That's one of those hormones that does that. Of course, diabetes insipidus results when that hormone is not released. So it's a form of diabetes that is not caused by the traditional means of, poor productions in the islets of Langerhans. Remember, the islets of Langerhans produce the insulin, and I can't think of the other one that it produces, but insulin in the pancreas. That's one of the main forms of diabetes that we usually think about. And diabetes insipidus is when there's not enough antidiuretic hormone released, and we lose a lot of hormones or a lot of electrolytes, and we get dehydrated because they're just constantly producing urine, they're not retaining water like they should, and they're losing glucose with it too. Okay, so hormones are also primarily responsible for the reabsorption of water and electrolytes by the kidneys. Aldosterone increases sodium and water reabsorption. And also water follows salt. So when we reabsorb sodium, water is going to follow. It just does, because that increase, remember what, like I said, when we have a higher concentration of an electrolyte on one side of the membrane, water is going to go to that side of that membrane to kind of dilute that down so it balances on both sides. So when we pull sodium from one area into another area, and more than likely that's going to be an active process, we're going to have some mechanism in there on that membrane that's actually pumping that sodium into another area, and water's going to just passively follow that. So when sodium moves, so does water. So water's going to follow that sodium. And then we have the renin-angiotensin mechanism. This one is important for regulating blood pressure. And this one is regulated by that juxtamedullary apparatus of the renal tubules. So when the cells of the JG apparatus are stimulated by low blood pressure, there's an enzyme, renin, that is released into the blood. Why is that important? Well, if that JG apparatus is not getting enough blood flow because the blood pressure is too low, it's going to stimulate the release of renin in order to raise the blood pressure. And that's that renin-angiotensin mechanism that they're talking about. The renin actually catalyzes reactions that produce angiotensin II. Well, what's interesting about this is renin converts angiotensin II, angiotensin I, into angiotensin II. Well, it's actually kind of a cascading effect. It doesn't directly do that. But basically, we have angiotensin I because of the presence of renin that's converted into angiotensin II. And I know you're going, what are you talking about, you crazy man? Just bear with me for a minute. So renin gets released. Why does renin get released? Renin gets released because the blood pressure is too low, and the JG apparatus has said, we need more blood pressure, right? More power, more blood pressure. So renin's released. It causes angiotensin I to convert to angiotensin II. Basically, it activates an angiotensin converting enzyme, an enzyme that's going to convert angiotensin I into angiotensin II. So that enzyme that converts that, renin, activates that. And what this angiotensin II does is it causes vasoconstriction and the release of aldosterone. This causes an increase in the blood volume and the blood pressure. So blood pressure comes up. So low blood pressure, release of renin. Renin's going to cause an angiotensin converting enzyme to convert angiotensin I into angiotensin II. Angiotensin II is going to cause vasoconstriction. Why did I go through all of that nonsense on this one particular thing right here? Because one of the key medications that we give to treat high blood pressure is called an ACE inhibitor. An ACE inhibitor, ACE, stands for angiotensin converting enzyme. So this enzyme that renin activates that converts angiotensin I into angiotensin II is called an ACE, an angiotensin converting enzyme. If we can inhibit that enzyme's ability to convert angiotensin I into angiotensin II, we're going to keep the blood pressure down. Now, I'm not talking about instances where the blood pressure is already too low and it needs to be brought up because we're talking about kidneys not being able to function. But I am talking about if there's an erroneous signal being sent by the kidneys that's releasing renin when it shouldn't, and the blood pressure is already safe, but it's causing the blood pressure to go up even more. This is one of the ways that we can control blood pressure. And it's an ACE inhibitor. There's tons of ACE inhibitors out there. One of them is lisinopril, and there's all kinds of different ones. One of the ways that we control blood pressure. One of the ways that we control blood pressure without having to use a diuretic, without having to use Lasix or something like that to make them lose water to lower their blood pressure, which honestly was kind of the way that they did things for many, many years before the the development of ACE inhibitors and the use of some calcium channel blockers in different ways to cause some vasodilation or to prevent vasoconstriction. That's ACE inhibitor. That's what ACE inhibitors do. They prevent the conversion of from angiotensin 1 into angiotensin 2. Okay? I know I went off on a tangent, and if you're feverishly taking notes because you're afraid I'm going to test you on that, I'm not. I'm not going to test you on what ACE inhibitors are. So don't panic over that. I just wanted to kind of give you a little bit more of a nugget of information, just so it hopefully helps your understanding. We talked about pH balance before. 7.35 to 7.45 is normal. Above 7.45 is alkalotic. Below that is acetic. Remember we talked about how that logarithmic scale and it's all backwards and you would think that it would be different than that. Remember, acidosis is high levels of hydrogen, free hydrogen, but it's going to show as lower numbers on that scale. Just try to get that in your head. We could spend a half a day talking about the math on that, and you still would probably have to struggle a little bit with understanding that. But that logarithmic scale that we're talking about is an inverse logarithm, so that's why it's kind of tough to understand and it's tough to explain. Just standing up here trying to explain it, we'd have to get really off into the weeds of the math of it. Kidneys play the greatest role in maintaining acid-base balance. They're not the fastest, like I said, they're not the fastest in correcting an acid-base balance problem, but they do play the greatest role in maintaining that. So they're constantly maintaining that, whereas the other systems may not have to be kicked in quite as fast. Other systems, of course, are blood buffers, bicarbonate that's in our blood, normally in our blood, and respirations. Of course, you know what bicarbonate is. I don't know if any of you guys know that. Next time you're at the grocery store, pick up a box of baking soda and look at what's in it. It's made of sodium bicarbonate, which is the exact same thing that's in our blood that acts as the buffer in the buffer system. So I'm just saying. So acids are proton donors. Remember, they release hydrogen. Strong acids dissociate completely and liberate all of their hydrogen in water. Hydrochloric acid is one of those. It will release all of its hydrogen when we put it in water. Weak acids, such as carbonic acids, only do it partially, but they're still acetic. They're just not quite as acetic. Bases, on the other hand, will accept hydrogens. They'll pull hydrogens in. Strong bases dissociate in water as well. We always think of bases as safe, the good guys, that kind of thing, because we're always combating the acids, the bad guys. Well, let me tell you, bases can be very, very bad as well. Bases, strong bases like the ones that dissociate completely in water, if you get them on your skin and get them wet, they will burn you severely. So bases can burn you just as easily as acids can if they're strong enough. So it's just the way that they work. They're very damaging. Weak bases such as bicarbonate and ammonia are slower to accept those, but they still do accept those. So we have all these molecules in the body that work very hard to prevent any kind of dramatic change in the hydrogen content of the body. So they're going to bind to hydrogen when the pH drops, when there's too many hydrogen, remember when that would become acidic, and they're going to release hydrogen when the pH rises, when there's not enough hydrogen, and we become alkalotic. There's three major systems that do this. We have the bicarbonate buffer system, we have the phosphate buffer system, and then the protein buffer system. The bicarbonate buffer system is the main one that I want to talk about. It's a mixture of carbonic acid and sodium bicarbonate. So we have a weak acid and a weak base. It's a combination of those two, and it's just a play on those two depending on what's going on. Carbonic acid is a weak acid, bicarbonate is a weak base. So we see hydrochloric acid, which is a strong acid. It's going to release a lot of hydrogen, and then we've got this weak base that's going to absorb that hydrogen. It's going to dissociate in water. It's going to absorb this hydrogen that's coming from the hydrochloric acid, and what we're going to do is we're going to take hydrochloric acid, sodium bicarbonate. We're going to create a weak acid and some salt is what's going to happen. And if you look at all the letters and numbers in here, they'll all match up. if you add them all up, there's 2 H's, there's sodium, here's the chloride, there's CO3. So they all match up, it's just that they dissociate. Now, don't think that just because you see molecules with those kinds of things in there that you can just randomly rearrange them. It depends on the molecule and depends on what substance you're putting them in and what their attraction is to each other. Remember, sodium chloride has a high attraction. Sodium's positive, chloride's negative. So they're automatically, when we get these, we put these guys in water and everything disassociates, those guys are naturally going to go to each other. Much more stronger pull than, say, here. It's just the way it is. So the reverse is also true. If we have a strong base, we'll take that bicarbonate, that weak acid that we've got, and we'll wind up with a weak base and some water. So it's just how things kind of play, that symbiotic play between the two in order to try to maintain normal pH levels. It's kind of what our body does. Respiratory system can work with this as well by getting rid of CO2, because CO2 plus H2O can combine to H2CO3, which can release a hydrogen and then HCO3, or all that can reverse and we can blow off CO2 and we'll have water. So it's a way that our body can manage this. Okay? So, in the renal system, when the pH rises, bicarbonate ions are excreted, hydrogen ions are retained by kidneys. When the pH falls, bicarbonate ions are reabsorbed and hydrogen ions are secreted. I'm not going to tell you what pH rising is. You need to figure it out. And pH falling is that acetic or alkalotic. You need to start remembering that. High pH is what? Low pH is what? You need to remember what those are without me reminding you what those are. You need to get that in your head now. So just, sorry, but you're going to have to do it on your own. All right, so as we're growing in mama's tummy, the kidneys begin to develop in the first few weeks. And they actually start excreting urine by about the 3rd month. So they're making urine in mama. I know it sounds bad, but it's really not as bad as it sounds. There are some congenital abnormalities, such as polycystic kidney and hypospadias. Common problems in children, young to middle-aged adults include infections. It's probably the most common. Most of the time they're caused by fecal microorganisms. Don't even ask. Suffice it to say, that's why they say front to back and not back to front. So even some sexually transmitted disease-related infections, streptococcus and that kind of stuff. So control of the voluntary urethral sphincter does not start until about 18 months. So if you're trying to train your 1-year-old to use the bathroom, don't be harsh on them. Basically what you're doing is you're just kind of trying to get them to learn the routine, or the sensations that their body's doing. If you can get your 1-year-old to 18-month-old to simply tell you, hey, I just did my business, and then go into the bathroom, then you're well on your way to getting them potty trained. Just don't expect a whole lot before 18 months. Usually it's about 2 years before you start to make really any strides, so don't expect more than that. And of course, complete nighttime control might not happen until they're about, 25 or something. No, I'm kidding, about 4. Some of you ladies out there went, oh my gosh. Urinary tract infections are the only common problems before old age. Usually that's pretty common. About 80% of them are caused by E. coli. Believe that. Renal failure is an uncommon but serious problem, which kidneys are unable to concentrate urine, and dialysis must be done to maintain chemical hemostasis of blood. Renal failure is one of those conditions where if you have a patient that's prone to renal failure, most of the time we won't give that patient a diuretic that's going to make their kidneys work harder, even though they don't function well already. So you'll see indications, contraindications, and all those things with every single drug that you'll be capable of giving. But you'll need to watch those contraindications pretty closely, because or the precautions, because it may say use with caution in renal failure. And those of you that are following physician's orders, whether it be by direct physician's order or whether it be through the use of protocols or written orders, you need to make sure that you clarify that with the physician and say, okay, did I tell you they had renal failure? Just so they know. And they may know already, but it's always a good idea to get that clarification, because all of us need to be an advocate for the patients that we're taking care of and not just be like sheeple and blindly just do what those above us tell us. Use your brain. They want you to. If you're ever working with me and taking care of somebody, I absolutely want your brain in the room. So if I'm going to do something boneheaded and stupid that I haven't thought through, by all means let me know. Just realize when we're dealing with physicians, some highly educated people with a lot of experience in those kinds of things, it's not so much what you ask, it's a lot about how you ask it. So you just got to be a little bit more cautious with those guys sometimes, even myself included. Not to say that I wouldn't be appreciative, but I might give you a kind of a snarky look, but I would be appreciative, and I'd probably apologize to you later and go, hey, good call, good catch. Way to save my patient from me. And of course, in men, we still have problems with urinary retention as well. As we get older, we have increasing feelings of urgency, meaning it's time to go. My poor mother, I remember her telling me one time that she knows every single clean bathroom between her house and Oklahoma City. So she knows which place to stop at and which place to drive by in case, and she's got them all mapped out, so she knows which one's what and she's going to use. And of course, sometimes it becomes more frequent. Oftentimes we're having to get up at night, nocturia. Sometimes it's incontinence, and then retention happens sometimes too. Okay, so that, guys, was chapter 15. I have some interesting news about chapter 16. I'm not going to lecture on chapter 16. It's not an all-time favorite of mine. It's the reproductive system. And some of the topics I'm just not extremely comfortable talking about. So what I've done is I've got some good videos of some good video information on that. Now, realize there will be a chapter exam on that, so it is important that you study that and you learn those things. But it won't be a huge part of any final exam that I give you. So the reproductive system is important, and it's important to understand some very basic fundamental things about it. When you go into your more specialized career, whether it be nursing or paramedic or whatever it is that you're going to go to from here, those courses will start to get into more detail specifically about some of those things. So it will be important for you to understand some fundamental and basic things about it, and that's what my intention is for you to get out of chapter 16. But I won't be lecturing on it. Sorry to disappoint. This is the last time that you're going to have to endure listening to my voice for this course. So good luck on your final exam, and hope you've enjoyed.